Good afternoon. Thank you for your presentation. Thank you also Devicare, their local partner Altea, and also ESD Bureau to invite me to talk about this product and their evidence. First of all, I want to start with this sentence. A human is the only animal that stumbles twice on the same stone and still chooses scissors again. This, it's not just in everyday life. Our patients don't play paper to beat the stone either. Sometimes because we, as urologists, get lost in the complexity of kidney stone management and kidney stone metabolism. Other times, perhaps, it's simply because our patients don't follow the advice we give them. So let's start now for the lesson. I will resume an introduction because we have explained a lot of things. You have explained a lot of things and excellent presentations. Kidney stone disease is present in 10% of the population, and the most important thing is that at least 52% of them have a recurrent, high recurrent rate. They have a stone and a stone and a stone. They play with the scissors, not with the paper. And in the last years, cost of the kidney stone disease has increased a lot. You have here the cost in USA between 1994 and 2000, and it doubled the cost. Now, 25 years later, I think this cost has increased hugely. Why? So you have explained excellent these days, but I will remember that there is a positive association between BMI and kidney stones. There is also an association between pure sleep factors, bad lifestyles, and also critically, you know, we are in the climate crisis. We have the urolithiasis, more heat, more sweat, so we produce more stones due to the dehydration. So first of all, we have to recommend our patients to change their lifestyle, their diet, to drink more water instead of sugar or soft drinks, not to eat ultra-processed food with high sugar, salt, and conservatives, not to eat animal protein and ultra-processed proteins, to improve their relationship with fruit and vegetables, and to go out, and to improve also their health activity, physical activity. Rapidly, when we have the patient with a stone, we have to know which type of stone they have. The most present in the stones are the calcium-based stones. Then we have uric acid stones, then the phosphate stones that could be associated with calcium, and finally cystine. These are 4 big groups. To resume, calcium stones like oxalate, monohydrate or dehydrated calcium oxalate stones are present with normal pH, with high calcium and high oxalate. Phosphate stones are produced in a high pH, even when we have UTIs, and calcium phosphate stones when there is a high pH and we have hypercalciuria state and maybe UTIs too. Uric acid, which prevalence are increasing due to this pandemic, the diabetes, are produced in a low pH, and finally cystine, you know, too, that is produced in a low pH. After know which kind of stone we have, Dr. Jensen explained us, we have to perform a metabolic workout with blood test, 24-hour urine, spot urine sample, and what? So what we have in the urine composition, a balance between promoters like oxalate, calcium, urate proteins, bacteria metabolism, and also inhibitors. I explained before about novel molecules, phytate, theromin, but also the old citrate, and other that scientists are looking for, like succinate or uromodulin or antioxidants, inhibit the stone formation. So, urine composition plus anatomic factors like slow urinary flow, Randall plaques, plus pH, we have the kidney stones. As I told you, we can recommend general recommendations: drink more water, change your diet, change your lifestyle, but patients don't keep these general recommendations. What are recommended for every kind of stone type? Let's see. For the calcium stones, EAU guidelines, after the 24-hour urinary collection, recommend us finally mostly alkaline citrate, depending of the alteration we find, but mostly alkaline citrate. And if there is hypercalciuria, they recommend to use thiazides to reduce the calcium in urine. If there is hyperoxaluria, they recommend us to give calcium and magnesium. Why alkaline citrate? Because alkaline citrate is a calcium chelator in the renal tubule, because it has a power in the crystal inhibition, and because urine alkalinization, increasing the bicarbonate in urine. But I explained you before about phytate as a maybe, and we have some scientific results, some clinical scientific evidence that could be, and is in fact, a very good inhibitor of the crystallization in stones. Phytate is the main storage of phosphorus in cereal and legume seeds. Inhibits the crystallization not only in kidney stones, also in vascular calcification, and has an antioxidant power to reduce the harm in the kidney. And phytate, and this is important, phytate levels in blood and urine are mainly influenced by oral intake, not naturally as citrate. Phytate, inositol hexaphosphate, is enzymatically hydrolyzed after consumption, and hydrolysis product also inhibits the crystallization of calcium oxalate crystals. In this study performed by Grasses and et al. With their team, we see here the use of citrate and phytate and how many times delayed to start the crystallization in both in two different places in artificial kidney. And note that the concentrations used in citrate and phytate were very, very different. And after 24 hours, the amount of crystals was the same whether the citrate was present or not. In contrast with phytate, noting that this much lower concentration used, the appearance of the first calcium oxalate crystals was delayed for more than 24 hours. And after 78 hours, only a few small crystals were detected. So we could infer that phytate is a more powerful inhibitor of the stone crystallization than citrate. You have seen also these photos, and I would like to emphasize the synergistic effect in the inhibition of calcium oxalate crystallization between phytate and magnesium. And this is a composition of lead control pH balance, phytate plus magnesium. We have also clinical evidence. Conte et al. Evaluate the risk of stone formation taking phytate versus citrate as inhibitory treatments. They separated 74 patients into 3 groups: control, taking anything, potassium citrate, and in fact 6.5 grams of potassium citrate per day, and patients taking only 120 milligrams per day. They then assess the risk of stone formation before and each after treatment by analyzing urine parameters that act as a lithogenic risk factors: calcium, phosphorus, citrate, and pH. And they classificate a positive or negative lithogenic risk. The results showed us that they demonstrated that 120 milligrams per day had the same power to inhibit decrystallization than 6.5 grams per day of citrate. So apparently equal, but using a huge quantity of citrate instead of phytate. More or less, in fact, 54 times lower concentration of phytate than citrate. In fact, in the citrate group, 3 patients passed from negative lithogenic risk factor to positive because they increased pH over 6.5. So, And another experiment, in vitro experiment, taken by Graces et al. They took calcium oxalate dehydrate kidney stones after lithotripsy, and they incubated in a normal oxaluric synthetic urine at 6.5 pH in an hypercalciurian state, in an artificial hypercalciuria. Note that increasing a lot the amount of citrate, the fragments were the increase of the relative increase of the weight of the fragments were the same. Instead of using phytate, only using 1.14, they reduced the fragment increase after this treatment, and this occurred in an hypercalciuria artificial urine. If we take the normal calciuria artificial urine, it seems that it has less power to inhibit decrystallization, but look at the graphic that they use only 0.76 of phytate, and they could inhibit decrystallization. They could reduce the fragment growth. In a study presented by Professor Sine today too, they analyzed more than 42,000 urinary stones in their center, and they note that 30% more or less were single component and the other 70% rest were mixed, mostly calcium-based stones. And they conclude in this study that treatment of mixing stones such as monohydrated calcium oxalate with carbonate apatite, or a combination of both calcium oxalate and carbonate apatite, can be challenging because therapy for calcium oxalate stones disease includes, in EAU guidelines, urinary alkalinization, whereas in the carbonate apatite stones is recommended not to alkalize, not is acidify. So citrate, which produces more bicarbonate in the urine, it's not a good treatment, could not be a good treatment to give to the patients with mixed calcium stones. So concluding about this product, pH balance, phytate plus magnesium is a good treatment. It's a good inhibitory product to unknown composition stones, taking into account that most probably are mixed and calcium based, obviously with calcium stones and patients with osteoporosis and hypercalciuria. And also we should treat patients before and after calcium stones intervention to improve stone-free rate and to prevent the formation of new stones from residual fragments. Going for the uric acid stones, the EAU guidelines advise us to alkalize or to give something to go down with a hyperuricosuric. They are not presenting the thebromine like an inhibitor. I told you before that thebromine is a xanthine present in the cocoa beans, and which molecular structure is very similar to the structure of uric acid. So they arrest uric acid molecules using this 7th position methyl group. We have here an example that when increasing theobromin concentration, the binding between theobromin and acid uric are increasing. So they arrest the uric acid molecules. But not only theobromin, also its metabolites that has the similar molecular structure and has this group methyl in the 7th position. I show you again these images, electron microscopy, that the use of theobromin and the metabolization of theobromin confers to the possibility to not nucleate and not aggregate these uric acid molecules, and crystals are thinner and smaller. In a similar experiment than with calcium oxalate fragments, Grasses et al. Took 15 uric acid fragments post-extracorporeal lithotripsy. The fragments were placed into a temperature-controlled flow chamber and incubated for 24 hours. A constant flow of 400 milligrams uric acid in synthetic urine with any theobromin, 10 and 20 milligrams per liter, passed through the flow chamber containing the calculus fragment, 5 in each chamber. A total of volume of 750 millimeters of synthetic urine passed every 24 hours, which is approximately the volume that passes through 1 kidney per day. The calculi fragments were weighed before and after the experiments, and the relative weight increase was calculated for each fragment. In this figure that I have shown you, you see a reduction of 80% of the relative increase in the weight of these fragments using the maximum dose of theobromin analyzed in this in vitro experiment. And also, the crystals had different shape and different size. Moreover, theobromin and pH has a good relationship. We know that in uric acid stone we have two alkalis. Yes, two alkalis. The time of the uric acid crystal formation increases with higher theobromin concentration and higher urinary pH. So, alkalizing urine to treat uric acid stones is okay. But if we alkalize with citrate, for example, and give theobromin, we increase the effect of the theobromin without citrate. In fact, only increase of 0.15, the efficacy of inhibit the crystallization increased by 64%. That's why you can give to your patients theobromin alone with 200 milligrams of theobromin extract to prevent 1 tablet per night. And the recommendation is to associate with your favorite urinary alkalizer, potassium citrate, magnesium citrate, bicarbonate, or citric acid. But if you want, you got it with lead control pH up, you have the potassium magnesium citrate to alkalize the urine with theobromin to enhance all the powers. I will pass in now 2 clinical cases from the Devicare Symposium of Clinical Cases. This is from the Puigverd Clinic in Barcelona. You see here an 89 years old patient with high anesthetic risk and a stone that 2 per 3 centimeters with an urinary pH of 5, negative urine culture, and the stone had 400 Hounsfield units. So could be uric acid stone. Instead of treat surgically, they treat the patient using lead control pH up, 2 capsules every 12 hours, 4 capsules every day, during 3 months. After 3 months, they perform a CT scan, and you see the result. The complete desolation without the need for a surgical intervention at the risk, and then after treat the stone, dilute the stone with these pills. The maintenance dosage were 2 capsules per day. I will present now another chemolysis of large stones, large Strahorn stone, of uric acid stone. You see here a 6 centimeters stone with 5 pH, and the treatment in this case were 1 pill every 8 hours. After 6 months, because the patient was asymptomatic, they performed a CT scan, and they observed a reduction from 6 centimeters to less than 1 centimeter, and the pH were up. 6 months later, stones were practically diluted following the same treatment. So to sum up, for lead control pH up and thebromine, you can use lead control to prevent as a chronic treatment, 1 capsule every 12 hours, and to try to dilute the stone, you can choose. The recommended dose is 2 capsules every 12 hours, or you have seen that you can use 1 capsule every 8 hours. For thebromine, thebromine is advised in patients with a recurrence despite maintaining correct pH levels, despite we alkalize the urine, and then patients are producing again and again uric acid stones, we should add thebromine. And also in patients who cannot take alkalizing agents like poorly controlled hypertension, chronic kidney disease, recurrent UTIs, or poor gastrointestinal tolerance, that's citrate, it's bad tolerated. To prevent, as I told you, 1 capsule every night, and if you want to associate with a citrates to chemolysis, you can do. For the last group of stones, the infective stones, as we have seen this morning, EAU guidelines recommend us to treat completely surgically the stone to treat the infection and acidify the urine. With what? With methionine. We have a very excellent clinical study with 10 years of follow-up, and they gave to the patients, 20 patients with recurrent strobite stone former. They performed a follow-up every 3 months with urine and blood parameters, and they gave 1.5 grams or 3 grams of methionine per day. The results were this. pH were maintained at 5.6 during the 10 years of follow-up without any metabolic acidosis. 90% of the patients did not develop any more infective stones, and important, this data, 84 had no UTI. So the product that Devicare suggests and we are using in our clinics, it's lead control pH down, 500 milligrams of methionine to acidify the urine. And as I told you at the first of my lecture, there are stones that combine phosphate and calcium, so that we can use phytate to inhibit the crystallization of calcium phosphate stones. I present this case. It's not a kidney stone. This is a man, 57-year-old man, that they perform a holmium enucleation of the prostate without complications. In the first consultation after the surgery, he went to the clinic and telling the persistence of mixed fluids, irritation, and pelvic and urethral pain. The doctor performed a culture that was negative and urine dipstick that showed a pH of 7.8. They performed a cystoscopy and they saw bladder neck sclerosis and dystrophic calcification and bruised stones. So they treat with a cervicotomy and they perform a holmium laser stone pulverization. They gave antibiotic despite the negative urine culture, and gave to the patient hygienico-dietetic measures. 2 months after this surgery, the patient went again to the clinic with difficult and pain when urinating, again with a basic pH, and they performed a blood test and they saw hypercalciuria. They performed a CT scan and they saw multiple prostatic calcifications again. So they go to the surgery again. They pulverizate the stones in the prostatic resection cavity. They gave thiazides to treat the hypercalciuria, and they started with lead control pH down 2 capsules per day. 1 year after the surgery, recurrent calcifications less severe thanks to thiazides and acidifying the urine. They saw a urine pH over 6.5, and that's why he had recurrent calcification but less severe. So you can see again another stricture of the bladder neck. They open again the 3rd time and perform the stone pulverization in the prostatic resection cavity with holmium laser. They gave again the specific diet plus thiazides plus light control pH down to acidify and to inhibit the crystallization of calcium phosphate stones, and to improve the alkalinization, acidification of the urine. They recommend to the patient to check himself the pH of the urine with a lead control pH meter associated with with the smartphone. And 5 months after all these surgeries, all this pathway, the urine were 6.5 or less. The patient went with an improvement in LUTS and pain and a complete absence of stones in the prostatic resection cavity. To take home message from the treatment of new treatments of stone disease, we have this. Phytate and magnesium are more potent inhibitors of calcium crystallization than citrate. Thiobromine is nowadays the only inhibitor of uric acid crystallization and a valuable alternative to prevent uric acid stones when alkalizing agents are contraindicated or patient has recurrence even though they are alkalizing. So thiobromine plus citrate has a synergistic effect as phytate and magnesium, enhancing the effects of both individually. And finally, methionine is a preventive treatment for infective stones because it acidifies the urine. I finished with the calcium with the stones. Let me few slides for novel molecules in the management of urinary tract infections. All of you know that UTIs are widely more present in women than in men. 40–60% of the women will experience a UTI during their lifetime, and the third of them will have an episode before age 24. These patients are very difficult to treat. They are very annoyed about their problem, and it's difficult to treat these recurrent UTIs, not? So, approximately half of the patients who suffer an UTI will experience another infection within the following 6 months. And this costs a lot in the healthcare system. So, using the clinical evidence we saw before about methionine, and they saw after 10 years that 84 patients had no more UTIs, they had developed methylphytin, a product associating L-methylphytin to acidify the urine plus phytate, but without stone. Yes, I will explain you after that. We can use this product not only to prevent infections, if not, we can use to treat with antibiotics. See that. The most effective form of phosphomycin is achieved in a very, very acid urine between 0 and 2 of pH. But this is not possible in the human urine. So the second most effective form of phosphomycin is reached at pH of between 4 and 6. Therefore, we must maintain urine pH below 6 to increase the effectivity of phosphomycin trometamol. the most widely maybe antibiotic given, to lower the pH and to enhance the efficacy of this antibiotic. Not only fosfomycin, there are different acidophilic antibiotics like tetracyclines and beta-lactams, also ampicillin and metamine ipurat. And I told you about phytide. Phytide has a great power of chelation of cations, calcium, magnesium, and also iron. Multiple studies demonstrate that the iron uptake systems of bacteria contribute to their virulence. By chelating iron with phytide, bacteria lose their efficiency in maintaining sufficient intracellular iron for rapid growth and metabolism. So, associating methionine plus phytide had a cellular stress generated by the acidification of the urine and decrease in the iron concentration, enhancing the bacteriostatic and bactericidal effects of both separately. We see here acidifying urine pH increases the effectiveness of fosfomycin. In fact, can multiply the effectiveness of this antibiotic up to 30 times. So the recommended dose could be in acute phase to enhance the activity of this antibiotic, 1 tablet every 8 hours for 5 days, plus the antibiotic, EVA. And for the prophylaxis, we saw here this graphic. This is a clinical study in kidney transplantation patients, and they saw that using methionine, they reduced the prevalence, the recurrence of the UTIs up to nearly 50%. So a good manner to use this new drug could be to acidify the urine, 1 tablet every 24 hours at night for at least 6 months, which is the period with high probability of recurrence of the UTIs. One more thing, because all of you maybe are using cranberry juice, Demanose, so note this important data. Technical data sheet from Spanish Agency for Medicines and Health Products has noted that this interaction between cranberries and warfarin and other anticoagulants like acenocumarol and new anticoagulants. And some cases have been reported more often, resulting in an increase in the international normalized ratio or bleeding. Personally, I have a patient with recurrent UTIs that the GP gave her product with cranberries. He had an ictus years ago, and with using this product, the cranberry juice, the international normalized ratio were changed, and they went to the emergency room not with an ictus, with another quite less dangerous cerebrovascular accident. But so then the GP sent me this patient, and I changed the cranberry juice with Demanose to methionine with phytide. So message to go home today or tomorrow: UTIs have a high prevalence and high recurrence rate. Recurrent UTIs have a great affection and quality of life of people and in the health system. There is a concern about antibiotic resistance, and we must find alternatives to the antibiotic use. Acidifying urine, it's one of these alternatives, and is useful to increase the effect of antibiotics and to reduce bacterial growth like bactericida and bacteriostatical effects. We can acidify urine with L-methionine, and we can associate with phytide with this product methophytin, limiting bacterial metabolism. And finally, before I open the floor for any questions or comments, just give me 1 more minute. A few months ago, I recorded this video one morning when I arrived at my hospital. I work in Hospital del Mar, Hospital of the Sea. As you can see, we have stunning views. And sometimes I take to myself reflecting on my thoughts and feelings, like this woman looking the sunrise, and let me share one of these reflections with you. I love endurology. I love lasers. I love the surgical tools, all our gadgets. I am a bit of a geek of urology, but our specialty is not just surgical, and we must not forget the important medical aspects as well, such as the metabolism of kidney stones. Thank you so much.